Yeah, thank you, Rosand. So my name's Gene Bowman. I'm an instructor in neurology here at Mass General, and I lead the clinical trial efforts at the McCance Center for Brain Health. It's a pleasure today to introduce Dr. Jonathan Rosen, who is a vascular and critical care neurologist at Mass General Hospital, professor of neurology at Harvard, and associate member of the Broad Institute. Dr. Rosen is an internationally renowned scientist, clinician, educator, mentor, and visionary leader. He's created a legacy of multidisciplinary teams that are successfully tackling some of the most pressing challenges in brain disease. His research program in cerebrovascular health, launched over 20 years ago, has been a world leader in high throughput genetic imaging and epidemiological studies of stroke. In 2007, Dr. Rosen launched the International Stroke Genetics Consortium to bring together the world's preeminent stroke investigators and created the Cerebrovascular Disease Knowledge Portal to share data widely. After founding Mass General's Division of Neurocritical Care and building it into one of the nation's top programs, Dr. Rosen stepped down to establish the McCance Center for Brain Health with Rudy Tanzi and Greg Fichion. He is now leveraging his extensive global collaborations, his network of former trainees, the rigorous science performed by his team at MGB, along with lessons he's learned from a life devoted to caring for patients, to launch the Global Brain Care Coalition. The coalition is an international network of outstanding academic health centers and their partners who have committed to a joint goal of reducing new cases of dementia, stroke, and depression by 10% in 10 years and 30% by 2050. It's a pleasure to introduce Dr. Jonathan Rosen. The title of his talk today is From McCance Center to Launching the Global Brain Care Coalition. Welcome.
Thanks so much, Gene, for that very, very generous introduction. It's such a pleasure to be talking to this audience. You know, as you know, when you're on Zoom, you have sort of no idea who's out there, but I know that there are many of familiar faces and also people I don't know. And so what I'm going to do is tell the story of how we got to this point. Please do. I don't know how. I guess it's between Gene and Hira. You'll have questions, but I'm hoping that I can. I will have left enough time for us to answer those questions. So let's get started. So I'm going to start really at the beginning of my own personal journey to reflect on the power of science to really improve human health. And with this lens, of course, is the focus on prevention. So that's me many, many years ago. I think I was 5 or 6 years old, and my best friend, Andrew Lippard, we were, just to give you a sense of how close we were, I had to have the very same bicycle that he had. Andrew and I grew up together until the age of 7, when he passed away suddenly of what became known as Rye syndrome. And at the time, his parents, his father was and still is a chemist, didn't know what to do other than to stimulate science to try and figure out a cure so that no family would have to suffer the fate of the Lippards. So they established this lecture series at Columbia at the medical school. And I remember when I was, I don't know, 8, 9, 10, going to these lectures, understanding nothing, finding them very intimidating. But over the years, what was very striking is knowledge accumulated. And because of the real foresight of the organizing committee, they were able to attract talented people, 5 of whom have since gone on to win the Nobel Prize. And the science has progressed. But in parallel to the fundamental science, the biological investigations, there was a real development in epidemiology. So if you go back to the 60s and the 70s, and in the early 80s, one of the experiences children around the world will remember, they're not children now, they're my age, is that when you get sick and have a fever, one of the things your parents would do is they would give you aspirin This is Bayer's Bayer children's aspirin. There was also St. Joseph's aspirin for children. And what was so striking was that the aspirin was sweet, it was candy. And so it really did, my own personal experience was, feeling sick, I associated with that orange flavor of St. Joseph's aspirin for children. But by 1980, the epidemiologists were beginning to notice an association between Reye syndrome and the use of aspirin among children. And by 1982, there were warnings issued, and the CDC had issued a warning to stop, essentially to begin to withhold aspirin from children when they had a fever. So you have 60s and 70s, the early 80s, and suddenly by 1982, the epidemiology has started to take root as practice. By 1999, there was an editorial in the New England Journal of Medicine, the title of which was "The Disappearance of Reye Syndrome, a Public Health Triumph." So what's really striking here is that it worked, that we had early scientific observations. And now if you do a Google search in 2023, aspirin in kids, the first thing you get is the association between aspirin and Reye syndrome. So why did this work? Well, first, the science progressed. Second, the science was easily translated into the moment when families were listening. So when your child is sick, it's hard to imagine a time of more heightened concern for parents. So that was just an easy opportunity to engage parents when they were ready to listen. The advice was simple: simply don't use aspirin. And there was collaboration across disciplines and all the stakeholders, from the families who made the decision to withhold aspirin from their children, to the practitioners who were treating those children, professional societies, governments, and industry, all of the marketing that went into advising parents not to use aspirin when their children had a fever. So fast forward to the life of a neurointensivist, and what I'll propose to you is that the experience of being in the ICU is something similar, because that's when, again, patients and their families come in and they're really worried about something terrible happening. So what we have found over the years in the ICU, particularly neuro-ICU, is when it's a time when suddenly something terrible has happened to a person's brain or the nervous system. It's a time when families and caregivers sort of stop what they're doing and are focused on their loved one. And it's a time when physicians and all of the teams, all of the team members in the ICU are focused not only on recovering lost function for the patient who is sick, but also preventing further injury. That's in part because so many of the injuries that we treat in the ICU are, they set off a cascade. So the brain is at high risk for the following days, sometimes longer, after an injury leading to an admission. What you've also got in an ICU, these are really the most luxurious settings, for lack of a better term. They're like the best possible hotel for somebody who's sick. You've got teams that are large and multidisciplinary. You've got a situation where these teams can pay attention to patients for as long as patients need their attention. There's not really a clock in the ICU. And you have continuous investment in the latest technology. So it's really a time when you can be most creative and devote the most resources to helping somebody. It's a model for the most advanced medical care. So one of the observations that many of us started to make among our survivors of traumatic brain injury, stroke, brain tumors, you name it, was the high rates of depression, anxiety, and PTSD among survivors. So teaming up with Anna Maria Rancionu, a psychologist in the Department of Psychiatry here, we began to study this. And what we learned was that rates of depression, anxiety, and PTSD immediately are high at hospitalization and tend to remain high over time. So these are for individuals who never had a history of PTSD, anxiety, depression. But once they are admitted, once the patient is admitted and the family members attend the patient, suddenly they develop anxiety, depression, and PTSD at high rates. So we began to ask, why couldn't this be prevented? And over time, Dr. Branciano and her team developed a resiliency intervention for prevention of PTSD, anxiety, depression, focusing on intervening in the ICU, but also on the survivor caregiver dyad. In other words, the treatment was aimed at helping more than one person. It was the pair. So this randomized clinical trial, this was a very preliminary report a couple of years ago, and you can see here that when you compare those individuals who did not receive the intervention, and that's the dotted line here, the dashed line, with those who did, you can see a dramatic difference in this case, rates of PTSD at 12 weeks, and you can see that those rates are correlated for both the caregiver and the patient. So now Dr. Branciano and her team are conducting a large prospective randomized trial of this intervention. But we were quite encouraged that the ICU in this case would be a terrific opportunity to initiate primary prevention. So from that experience, the question became obvious. Why not make primary prevention of brain disease a cornerstone of primary care? And I was fortunate to start conversations with Rudy at that time. And I think they probably started before 2015, but from 2015 on, we were convinced that this had to be a focus for the future of medical care. And we began to strategize about how we could launch a center where we could focus on primary prevention, making brain health a part of routine medical care, as we said at that time, and focusing on not only what individuals could do to prevent brain disease, but also on the development of the kinds of drugs that could be available widely, inexpensive, and safe, that could be taken for years to prevent neurodegenerative disease, for example. We were joined then by Greg Piccione, a psychiatrist, director of the Benson Henry Mind Body Institute. And the three of us developed a vision, and were really fortunate through Rudy's long-standing collaboration with Henry McCance to recruit Henry McCance as the founding philanthropist for what became the McCance Center. And with this center, we've really trained our lens on prevention. We recruited a terrific dual-trained neurologist, psychiatrist, and also global health expert in Zaina Shamali, who had been thinking about these issues as a clinician for a decade plus, and launched a clinical program and really began to focus on how we could help patients with primary prevention. So now, to take a step back, I think it's important that we recognize that we are in the midst of a global pandemic. It's not as acute as, for example, COVID-19, but the impact on society is probably much, much bigger than COVID-19 ultimately was. So if you just think about dementia, there were more than 10 million new cases around the world in 2022. And because because prevalence rises as the number of people among the aging population rise, there will just be a continuous increase in the number of new cases as the number of people over the age of 65 increases around the world. The expectation is that the 57.5 million people living with dementia in 2019 will swell to 152 by 2050. And very definitely the most vulnerable will bear the greatest burden because the percentage change between 2019 and 2050 is expected to be highest for those living in the lowest quintile by sociodemographic index. Stroke, similarly, a real scourge for our population around the world, greater than 12.2 million new cases this year, causing 6.2 million deaths and 144.8 disability-associated life years. And again, by 2050, everything gets worse. And then depression, and we'll come back to that, is so prevalent, and its prevalence among the aged, those over the age of 60, is generally underappreciated, but most statistics demonstrate at least 30%, if not more, of individuals over the age of 60 will suffer from depression at one point. So this is the opportunity that led to the formation of the Global Brain Care Coalition. So I don't have to tell this audience that there's a substantial body of evidence demonstrating the role of modifiable risk factors in the development of stroke, dementia, and depression. This is something that's been recognized now, not just by public health bodies, but also increasingly by professional societies like the American Academy of Neurology, the European Neurological Societies, and many of the world neurological societies. Everybody is beginning to call for a movement to take advantage of this knowledge that prevention is possible. So what that prevention would look like would be sustained lifestyle and healthcare choices. And that's the focus of, for example, the primary care agenda for brain health that was issued by the American Heart Association and endorsed by the American Academy of Neurology. Again, imagine if we could harness lifestyle choice and anticipate the impact on the number of strokes, dementia, and depression that we would see. There would be a substantial reduction. So how can we convert the rigorous science, the epidemiologic science, into impact on the lives of everyday people? How can we take perhaps the playbook of what happened with Reye's syndrome and be successful? So we've been having conversations at the McCance Center now for 2 years at least. We realized we needed to set ourselves a goal. And so we decided that it was to be 10% fewer cases of dementia, stroke, and depression in 10 years, 30% by 2050. In that goal, in this mission, is the necessity, for example, to measure, because we'll never know that we're successful unless we're actually measuring the number of new cases every year. So how to begin to tackle that goal? Well, we decided to listen to our patients, because it was our patients who were driving us to figure out what they could do. They were coming to us, asking us to help them prevent themselves from suffering the fates of their loved ones, whether it had been dementia or stroke, and in many cases also depression. So following our patients' lead, we sought to answer the question we were getting commonly, both in the ICU and in the clinic. What can I do to take good care of my brain so that I don't develop dementia the way my mother did, or a stroke the way my brother did? So we began that journey by looking at the lists of modifiable risk factors that were associated with dementia and stroke. And we developed what we call the brain health score. And we started working with patients on the brain health score, but we immediately found that there were a lot of challenges when we used the term brain health. One was that there was no standard assessment of brain health available, so we couldn't answer the question, well, is my brain healthy or not, in an easy way. We also found ourselves getting stuck with having to answer questions like, My husband's had a stroke. Does that mean that his brain will never be as healthy as mine is? Or my son has schizophrenia. Does that mean he will never be able to achieve brain health? And so what we found is that we were getting into discussions where it was very, very challenging to avoid actually increasing the stigma associated with brain health, lack of brain health, brain disease. And that was just a recipe for actually interfering with engagement, which is really what we were after. We were after engaging people in their own healthcare. So over time, what became clear to us is that we weren't really interested in talking about brain health. We were interested in talking about brain care, because the question that our patients and their family members were asking us was really, what can I do? What can I do to take care of my brain? And the nice thing about talking about brain care was that anybody could take good care of their brain, regardless of where they started, regardless of whether they had developed a brain problem, a brain disorder, or not. And also, this was about agency, and this has become really crucial to the way we're envisioning the Global Brain Care Coalition. It's really about giving agency to individuals, so individuals can make the choices to take good care of their brain, to give themselves the outcomes that they seek to have for their lives. So the McCance Brain Care Score was developed and piloted in McCance Brain Health Clinic, and it adhered to the principles that we learned from our patients were really important. The score had to be simple, it had to be motivating, it had to reduce rather than increase stigma, it had to have very high face validity, scientific validity, and be distinguishable from the vast for-profit marketplace of brain health treatments that are advertised on all social media, on television, newspapers around the world. It had to be culturally tailored so that patients, regardless of their own background, would engage with using it. And it had to be a vehicle for strengthening trust, because with trust would come the patient's commitment to themselves if they trusted the information that they were acting on. So just to give you a sense, there have been other scores out there. Certainly the most well-known is Life's Essential 8 from the American Heart Association, which lists the key measures, 8 key measures to reduce your risk of heart disease and stroke. And there's the Stroke Riskometer, which is a lovely app that helps you identify your risk for stroke if you plug in your risk factors. But what we found is that we learned from our patients that they were interested in learning something they could do, and telling somebody that your risk is high and frightening someone turned out, at least in our experience, not to be the most engaging way to bring patients in to a return visit, for example, to see us. So the McCance Brain Care Score kind of flipped risk prediction on its head. The higher your score, the better your brain care. And we really did focus on engagement. In other words, was this score something that patients would take, they would share with others, and they would want to bring it back for a follow-up appointment? The other thing about the brain care score is it focuses on the 3 most common conditions of the brain as we age: stroke, dementia, and depression, rather than just stroke or just heart disease and stroke. Another innovation of the brain care score is that we added social factors: stress, social engagement, and meaning in life, because the evidence is clear that these social factors play such a strong role in our risk for not just dementia, stroke, and depression, but many other chronic diseases. So that it offered a way in to give people many choices as to how they might start improving their brain care. So just to give you a sense of what the brain care score, how it performs, this is work led by a whole, it's a huge team. and led in particular by Sanjala Singh, who recently joined us as a faculty member. And what you can see here is the brain care score reconstructed in the UK Biobank, which is a population-based study in the UK of about 400,000 people that's been ongoing for 15, 16 plus years. And Sanjala and her team were able to reconstruct the brain care score from the baseline data at the time study participants were enrolled. And then based on the brain care score, divide individuals into 5 quintiles. And then the green here represents those individuals who had a brain care score in the top quintile at baseline. The red group represents those individuals with the brain care score in the lowest quintile. And what you can see here for each of these curves, this is the cumulative incidence of dementia over time, cumulative incidence of depression over time, and cumulative incidence of stroke over time. And the curves diverge substantially for, especially when you compare the greens and the reds. But for all 3 of these brain conditions, and then this here in the bottom right represents the combined cumulative incidence of the 3 conditions. So the higher your brain care score at baseline, the lower your risk of developing dementia, stroke, or depression over the next, on average, 12 and a half years is how long follow-up was for these individuals. And keep in mind, these individuals were all free of these conditions at baseline. So we're looking at first-time incidence. One of the key findings from this study was that the impact of the brain care score appeared to be highest in those whose baseline brain care score was recorded before the age of 50. In other words, these were individuals, the younger individuals enrolled in the UK Biobank. And in this group, what we found was a 5-point positive difference in the brain care score was associated with a 59% reduction in risk of developing dementia and a 48% reduction risk of developing stroke within an average of 12 and a half years. So that's pretty important, that time span, because if you think about, for example, the burden of who pays for healthcare for individuals age from less than 50 to, let's say, 62 and a half, that's still mostly employers and private industry in the US because Medicare doesn't assume responsibility until age 65. So lots and lots and lots of stakeholders have lots to gain from our improving our brain care score when we are younger. So not surprisingly, and this is work led by Jasper Senf, a postdoc working in our group, what's good for the brain is good for the heart and the body. So again, these are the brain care scores in the same group of people. You've got the green representing those in the top quintile, the red in the lowest quintile. And now what we have here is cumulative incidence on the left of cardiovascular disease, and this is just heart disease, heart failure, and ischemic heart disease, as well as on the right, cancers, lung cancer, breast cancer, and colorectal cancer. So after we saw these data, it became clear to us that one thing we could propose was that the brain care score could become a simple checklist in primary care. If all that primary care achieves is a high brain care score for its participants, the amount of suffering, the amount of disease, the amount of morbidity and mortality that will be prevented is just staggering. So it really is that simple. The brain care score, when it was first published, was taken up it was very gratifying by the local, national, and international media. And on the basis of that media coverage, we were inundated with requests about the brain care score, with requests to collaborate from former and future collaborators around the world. So that's what gave us the sort of vision of how we could really achieve this goal to reduce dementia, stroke, and depression by 10% in 10 years, 30% by 2050. And that is to work together in a global team. And so the way this has evolved is if you use the language of the pandemic, which is absolutely accurate, you have to imagine that each of us has to play a role if we're to be successful in ending this pandemic. So the question is, what can individuals do? Well, once individuals learn about the brain care score, they can take care of their circle of loved ones. So adopt them, perhaps then imagining that that's my circle as an individual in a family, that I will work to help achieve 10% fewer cases in 10 years. Healthcare practitioners can adopt their practices. Healthcare systems and payers, their patient mix, and geopolitical regions like cities and states can adopt their citizens. If each of us adopts a group of individuals and works with that group to help them achieve better brain care, that would be a way to reduce the number of cases of dementia, stroke, and depression around the world. And so through the generosity of the philanthropic supporters of the McCance Center, we've been able to work with some of our global partners to launch pilot projects to achieve just this. So our collaborators at Yale have adopted the city of Derby, Connecticut, and they're beginning to figure out ways in which they can integrate brain care across the population, engaging all citizens in their own healthcare, their own brain care, to protect themselves from ever developing heart disease, brain disease, cancer. We are working now with the city of Hamburg, which has really been an innovator in developing what they call the active city approach, which is engaging all of their citizens, 1 million plus citizens, in physical activity for their health. Now, there's another aspect, though. If we're really to be certain that we are successful in our ambition, we've got to find a way to count the number of new cases in a manner that's reliable so that we can compare this year's results to last year's results and know that we are seeing a difference in the same population samples. And so that exists. For example, I think we were all exposed to it during the COVID-19 pandemic. There were reliable ways of assessing case counts, of assessing viral load in the wastewaters, for example, as a way of checking to see how we were doing in our fight with the pandemic. We've got to build those systems for dementia, stroke, and depression if we're to be successful. And I'll talk a little bit about how we're doing that later on. Engagement with communities and building trust is vital to being successful in fighting this pandemic. We will have to build partnerships to work with populations and stakeholders to tailor interventions and outreach to local cultures, to local needs, and this has to be part of really a group movement that involves governments, payers, philanthropists, et cetera. Brain care has really become embraced by our global collaborators, the concept of using the brain care score. And so we finally have something to implement that actually could be an effective vaccine, if you will. So that's also a pillar of this pandemic approach. And then, of course, learn as you go, because we have to be able to learn the lessons in real time so we can adjust our strategies to ensure that ultimately we land on a strategy that's successful. So the first meeting of this coalition was almost a few months shy of a year ago. It was June of last year in Somerville at Assembly Row. We were thrilled that our partners from Yale and University of Alabama, Birmingham made the trip to spend a day and a half with us, brainstorming and starting to think about the kinds of joint projects and fundraising we needed to launch. And then ever since the publication of the first brain care score paper in the winter of 2023, or actually the fall of 2023, late fall, we have really grown substantially, exponentially, frankly, with the number of groups and leaders who are engaged in this effort of treating this pandemic of age-related brain disease as exactly a pandemic. And so we now have weekly calls where groups join as they can, but the focus has been on each of us learning from the other and beginning to figure out what science has to be done to advance this approach to the pandemic, and what business planning and strategy has to be done. So this is a mix of all of the disciplines necessary to make an impact on this pandemic. And I'm delighted that we were just recently joined by Us Against Alzheimer's and the Davos Alzheimer's Initiative as well, particularly with a focus on how are we going to develop these surveillance systems. So how does the Global Brain Care Coalition work? Well, we're still figuring that out, but the best way to understand it right now is that the mission of the coalition is to reduce the global burden of dementia, stroke, and depression by ensuring that patient-centered brain care is basic health care for all people everywhere. We work with private and public healthcare leaders, governments, and philanthropists to make lifelong brain care simple, scientifically driven, and accessible for billions of people. And then, embracing those two statements, each coalition member contributes its unique strengths to the overall mission, depending on their local expertise. So for the brain care labs, we can say that the brain care labs and our global network of scientific collaborators make the scientific discoveries and innovations and train the next generation of scientists essential to achieving the coalition's mission. And then, just as an example, each site can modify that final statement based on what their own local expertise or their own local aspirations are. So I end by asking all of you in the audience, how can your team contribute to ending our pandemic of age-related associated brain disease? It's going to take all of us. And so the job of the McCance Center in particular is to help organize, to figure out how these contributions can basically work in synergy. How can we ensure that there's as clear communication across all the members of the collaboration of the coalition? And also, how can we ensure that the stakeholders are all brought together? Because only when we bring together all stakeholders will we be successful. So there's a lot of acknowledgments here. The brain care score has been a huge team effort. And this slide really doesn't do justice to all the people whose intellectual contributions have been important, but we've done our best to really include so many of the folks who have made not just intellectual, but also they put their sweat into this. I really want to acknowledge our team, the Brain Care Labs. This is the group that really does all the work behind the science, driving the science to brain care, understanding what the questions are that we have to answer, and then figuring out the methods to answer those questions. We would not have gotten to this place without the extraordinary support of the McCance Center Advisory Board that Henry McCance pulled together. These are people who have taken their valuable time to advise us on strategy, to hold our feet to the fire to get us to this point. And even more fundamental to our success has been the support of Merit Skovic, the chief of neurology at Mass General, Maurizio Fava, the chief of psychiatry, as well as Meg Kotarski, vice president for neurosciences. What we are working on, what we are doing is not traditional academic neurology. It's not traditional anything neurology, but thanks to the foresight and the support of our board and our oversight committee, they've recognized that this is such an important, it's such important work, and that it's appropriate and in fact must be done here at MGH and MGB. So I'll just conclude by saying the journey really has been such a pleasure, particularly to share it with Rudy and Greg, who've taught me enormously, and also who have been so supportive of crazy ideas. Zaina Shamali and her extraordinary clinical experience, it's really been a privilege to have Zaina contributing. And I just want to conclude with calling out Chris Anderson, who is my scientific partner, has been my scientific partner for well over a decade. And it is just such a pleasure to be able to work with somebody who can move so quickly from field to field and so generously from question to question. It's really been a thrill. So with that, I'd be delighted to answer questions. Thank you for your attention.
Thank you, Jonathan. Let's see, did we have any questions in the chat? I don't believe so, but maybe while people are thinking, I have a couple questions for you, Jonathan. And of course, I've attended your lab meetings several times periodically and seen this evolve over time, and it's quite exciting to bring it to publication. I'm wondering about what are the main barriers you think to having this disseminated or implemented globally at a fast pace? I mean, what have you come across? I know you're developing this coalition, and maybe that's a solution somehow, but what do you think are the big barriers for more widespread use of the brain care score developed here at the McCance Center?
Well, that's a great question, and I think deserves a very lengthy answer, which I will try to avoid. And I'll focus on one aspect. So when Rudy, Greg, and I got started, we were really focused on integrating brain health, as we were calling it then, into primary care. And so we spent a lot of time working with primary care providers, the large proportion here at MGB. What we learned was that our primary care system is so overburdened and is so under-resourced that to bring something new like brain health and what ultimately became brain care into the system was almost insurmountable in terms of the challenges. And the challenges really were nobody working in primary care had time for anything new. And unfortunately, we've seen a further erosion in the primary care workforce. So a lot, and this is not unique to the United States, it turns out this is happening everywhere. So I think the main barrier, to come back to your question, that I would focus on today is how do we get brain care to people outside of the healthcare system so that people become engaged and then people become the agents of brain care. They bring it to their PCPs, and we're going to work on that. That's very high priority for us.
Okay, thank you. We have a couple hands up. Dr. Su? Johan Su?
Hi.
Hi.
Yeah, can I ask you? It's very nice talk, Jonathan. It was very nice. And so I'm just wondering if based on the brain care score, are you planning to demonstrate it? It's obvious if you have good brain score, it's you can prevent those dementia and stroke and depression. But at the same time, to demonstrate if you increase this much value of the brain score and you can prevent this much, showing it scientifically, are you planning some longitudinal clinical trials to show each individual score getting better, and then eventually you can prevent this much to demonstrate, actually to show the people and encouraging people to follow?
Yes, absolutely. We have to do that. That's the big question. The question being, as you put it, if I start off with a brain care score of 14 and I raise it to 19, does my risk go down in the long term? And that leads to all sorts of other questions. If you raise it to 19, how easy is it for people to keep it at 19 or get it to 21? We must answer all those questions. I just want to highlight, though, we're in a slightly different position from your team and Rudy's team, because you're developing drugs. And when you're developing drugs, you can't test them for efficacy before proving they're safe, right? We, on the other hand, with a brain care score, there's no risk to it. So we can both, on the one hand, say, let's do it. And on the other hand, conduct the essential research that you're suggesting we need to do. So we're doing both. And that's really the mission of the brain care labs, all your colleagues who convene at AR on Tuesdays and Wednesdays, is to figure out what studies we have to do, what human studies we have to do, and to get them funded and to do them.
I think one of the potential avenues for wider use may be clinical trial evidence. I think your primary care physicians are worn out, but I think with the clinical trial result, it might be more compelling even for policy, at least here in the United States.
Absolutely.
Why don't we go to the next question? Alex Rodriguez, please take the floor.
Okay. Hi, Jonathan. Great talk. It's all very interesting. One question I thought of was, is there a relative weight factor to each category in the brain care score? So I can imagine a patient asking their PCP, a patient that eats decently but doesn't exercise. I can imagine them asking, well, how do I most rapidly increase my brain care score? And do we have the knowledge from the, for example, UK Biobank data for the physician to say, yes, I think you should maybe start eating healthier, or I think you should start exercising because that's your lowest point on your brain care score?
Terrific questions. Thank you for those. So what I'll say is I'll try to break it down into slightly, parse the question. So I think they're embedded in your question first is, do we know can we quantify the relationship between risk factors and ultimately reducing your risk, right? So ideally, you'd like to be able to give a score, as the brain care score gives certain numbers of points. We'd like those points to reflect with each additional point you earn. For example, at blood pressure, in this case, you get 3 points. That's once you get to 3 points, you sort of maxed out the effect of blood pressure, and you can turn now to diet or something else. The other question is practicality. What's going to get somebody to act? So the scenario that you described was the individual who wants to know what step they can take that'll have the biggest quantitative impact on their risk. Did I get that right?
Yes.
So it turns out that that latter question really is about what is easiest for the individual to do. Because even if, let's say, I were to say, losing 20 pounds is the best you can do, that's really hard to achieve. So you wouldn't want to start with that in the doctor's office. You want to start with something else. The other thing is that it makes sense to imagine these levers as all connected. So it's impossible to isolate one risk factor. What is going on? Anyway, it's impossible to isolate one risk factor from all the others, the impact of one risk factor. So you move one lever and all the other levers get moved. So what I would say the most practical answer to your question is, whatever the patient is most motivated to do, you want them to start with that. But scientifically, there's a large group in our on our team looking at how best you can answer the question, blood pressure, is that the most potent way to reduce your risk, or exercise, or they're trying to answer those questions. So we at least can get the numbers of the brain care score to be as scientifically accurate as possible.
Great, thank you.
Let's see. So we have Dr. Fischione as a comment in there, just a glowing compliment, Jonathan. Are you able to see the chat there? I don't think there's a question embedded.
Thank you. Thank you, Greg.
Are there any other questions?
I'm at the Red Sox game, and I just let Henry McCance know you gave a brilliant lecture, and you could probably hear let you see Henry over there. Game, so I'll let him know what a great job you did.
Thank you, Rudy. Give him our love.
Let's see if there's not any other questions. We have a little bit, we're fortunate to have Dr. Rosand here. Maybe I'll ask one more question that came up during your presentation. As a product, the brain care score as a product, how much does it cost? Like, for example, if you were to deploy this everywhere, does insurance cover it for, the laboratory aspects if they're not already available? Have you thought about a cost analysis with the brain care score?
Yeah, so right now, insurance covers certain tests as part of routine primary care, other tests only when certain risk factors are present. So for example, the hemoglobin A1C, which is a test that's only reimbursed traditionally for people who have other risk factors for diabetes. So how to convince payers to pay for it? It's part of it goes back to the question about clinical trial evidence, right? We need to show that if you raise your brain care score, you're going to reduce your risk, and so insurers will pay. That they'll change their reimbursement patterns. Another way to get at that, though, and this is work led by a number of folks on our team, including Rainier, I don't know if he's on the call, and Jasper, is to figure out ways to ask questions that are surrogates for these laboratory tests, but don't require a blood test. So are there questions you can ask somebody that will give you a pretty high probability of there being hypertension? Have you ever been told you have hypertension, or have you ever been prescribed medications, or there are all sorts of questions that they're looking at. And so can we reduce the cost of the brain care score to zero as best as possible to make it accessible no matter where you are? And then, over time, as you get engaged with it, then the laboratory testing can come in later. Then the other thing about accessibility and cost, we want to make it so that it's available in multiple languages. And so there's a question in the chat about languages. We have a Spanish version that Zaina developed, and we have a German version that our collaborators in Germany have developed. We have a French version that our collaborators in Switzerland have developed, and there's a Chinese version. And so that has to be done, but then you've got to validate them as well. So all of these steps are important steps. And our job, I think, is to remember that, yes, we got to do the science, but we're not putting anybody at risk by throwing the brain care score out there, thankfully.
And I'll just mention that last question was from our new administrative director, Elizabeth Fonseca. Are there any other questions? I'm full of questions here. I have one more. If we take one more minute, I was looking at the data from the paper that Dr. Singh was the first author, and it looks in the age group of less than 50 years old and with 15 years of follow-up, how do we design a trial? And maybe we don't answer that here, but how do we design a trial in that age group with these outcomes of incidence of disease in such a young population that don't have the disease? Something to think about, perhaps.
Well, you are the clinical trial guru, so I would love it if you thought about that. We have a lot of orthodoxy around the way we think about clinical trials these days. One of them is it's got to be 4.5 years long, to suit the NIH funding cycle. Another is that they've got to be, they can't be huge and look at real world outcomes, because that's not practical or it's too expensive or whatever. And I think there are so many new ways to think about clinical trials that it's worth, I would love to make that a priority for us to do one of these kinds of clinical trials, because I bet we could engage enough people, we could find creative ways to fund it, But we have to be patient. That's the key. And wait for the outcomes to occur.
Yeah, perhaps there's a convergence of the questions and the comments with this bubbling up clinical trial idea. Maybe Dr. Singh can help us think about that. All right, if there's no other questions, this is really, oh, Jonathan, did you have something else?
I would just say there's one of the great things about the coalition is we have access to the world's expertise. So this is the kind of, there are definitely coalition members who are thinking about just these issues. And one of the sort of the learnings for me has been, you know, we are often US centric, but there are a lot of countries out there that are much better places to do the kind of research we want to do. And so it's very likely that, you know, the best answer to your question, Gene, is going to be conducting a clinical trial in a country other than the United States of America.
Okay. Well, I think we will conclude there unless Rudy wants to tell us the score of the Red Sox game.
I think we lost Rudy.
Maybe we lost Rudy. Okay, fair enough. Well, Dr. Rosand, thank you so much. What a wonderful presentation.
Thank you.
And thank you all for attending the McCance seminar series, and Tahira for organizing. Thank you very much. That concludes the
Thanks,
session today. Take care.
Have a good day.
Bye.